Thank you very much, chairpersons, for kind introduction. Probably I am the odd man out here among all you researchers. I am primarily a clinician, neurovascular interventionalist. Stroke is something I deal day in day out from last 2 decades or so. Stroke, any cessation or pause of blood supply to brain, commonly called as paralysis. So what WHO says, any kind of sudden onset of facial weakness, arm or leg weakness, or speech change could be a stroke. Well, the importance of stroke is we have 22 lakh strokes every year in our country. This is the second leading cause of death in our country. This is the independent leading cause of disability in our country. So this is the meanness of the problem, just to brief you about stroke or paralysis or brain attack. So there is a lot of problem in terms of stroke treatment. Stroke clock, which is the topic. So the most, the problem with stroke, I mean, all of you know about stroke, apart from the clinical, as I told about the clinical history, which makes you to diagnose a stroke. So fast WHO, which propagates, as I said, facial weakness, arm or leg weakness, speech disturbances. So T is timely intervention. So I always say fast, it's not me. WHO says that you disseminate this so that you diagnose a person when you are standing on a railway station or in a market, so you should know fast. So rest of the talk, even if you forget, I would request you to remember fast for my today's talk. Well, so the problem with stroke, apart from clinical, diagnosis, what happens is you have to do some imaging, CT or MRI, to make a confirmed diagnosis. And just to tell you in brief, strokes are of two types. Brain strokes, either it is because of reduced supply to your brain, that is ischemic stroke, which is 80%, and sometimes the blood vessel in brain tend to rupture, that's brain hemorrhage, that's in 20% of patients. So the problem with acute stroke management, so cell-free plasma DNA, which I will be talking today as a biomarker for acute stroke, this is very interesting. This is an area where probably molecular biology meets acute medicine. Why I am saying timely intervention? Why time is so important? Every minute we lose thousands of neurons when you have a stroke. So you have to have something in terms of treatment which is standard worldwide today. If you have a stroke patient, within first 4.5 hours, you do a clot busting injection and you open up the brain artery by that simple injection, IV injection. So that's first treatment. Second, over last decade, the major breakthrough came when you have clogged or blocked brain arteries, do an angiogram like what you do for heart, open up the blood vessel in the brain, that's the procedure called mechanical thrombectomy. So this is standard worldwide, mechanical thrombectomy. And I tell you, even in the most of the developed nations, the people who require need mechanical thrombectomy, only 10% of them receive mechanical thrombectomy. This is not our data, it's US data developed. In our country, probably it is less than 1%. Those who need it and those who get it. In my own state, every year we need 50,000 thrombectomy and we end up doing 2,000 or 3,000 only. The reason being, number one, awareness, second is cost. So when I was doing thrombectomy, it is a costly procedure. So the whole idea of this biomarker came because there is no established biomarker for stroke anywhere in the world. So what I was encountering, that can we have something which is simple, inexpensive, fast, rapid, robust, early diagnosis of stroke. Not only diagnosis, something which can prognosticate about stroke. Okay, this much level, the patient outcome is going to be like this. It can suggest you treatments, optimize your treatment plan, whether this person requires a thrombectomy or IV thrombolysis or not. It can predict complications. This can predict complication. So this is something kind of dream biomarker which doesn't happen in reality probably. So the whole idea of doing this, Just to make it very simple, we have neurons in our brain. We are all millionaires, 100 million neurons. Anytime, any cell that breaks will release DNA. So that's cell-free DNA. So once the blood-brain barrier is breached, you have release of cell-free DNA in your bloodstream. So this is like 160, 170 base pair size cell-free DNA which is released into your blood circulation. Now interesting thing is, if you measure this, if you quantify, normal person will not have much cell-free DNA, very negligible amount. But if there is a stroke, there is an amount of neuronal insult happening in your brain. So the level of cell-free DNA would be higher if there is a higher insult. If it is low insult, it will be less. So you can, and cell-free DNA interestingly has a very short half-life, 15 minutes to 1 hour. So this is a snapshot of dying neurons. So this is the interesting thing about this. This is a snapshot of dying neurons. On a bedside, you can quantify it on the day 0, you can quantify it on the day 2, day 3, and you know the progression, whether the stroke is progressing or it is responding to your treatment, or you need to change your line of treatment, because nowadays we have very innovative new treatment options. But something which is like the costing, which was like a 300 rupee test, if it can give you not only early diagnosis, prognosis, treatment optimization, differentiating between hemorrhagic and ischemic stroke, source of origin of stroke. Stroke happens because of either some blockage in your large vessels or some thrombi coming from your heart up in your brain. That's cardioembolic stroke. One is large vessel disease. So it will identify the source of stroke also. So whenever there is a stroke, as I was saying, there is release of this is how usually brain neurons dies by apoptosis. You all must have heard this is the programmed cell death where there is not much of inflammation. But when there is some sudden cessation of blood flow to brain, they die by necrosis or necrosis apoptosis. If there is too much inflammation, that's called pyroptosis. So this is the whole slide showing that inflammation is important component of stroke or heart attack. Well, let me put it in a very simple way. Cell-free DNA, just to put you very simply, cell-free DNA, the DNA fragments, these are DNA fragments in your blood circulation, okay? When you have a pathogen entering in your body, a bacteria or a virus, so they have some immune receptors in the body. So that is what you call pathogen associated molecular patterns. Cell-free DNA, this free DNA also acts like a DNA or a virus, because this is sensed by our body, by TLR receptor AM2, then this gas sting pathway. So if there is a massive release of cell-free DNA in your body, they are going to go to different places in your body. They would incite inflammation, not only in the brain, everywhere in the body. So what happens, many times you don't have on the day 1 itself, patient start, or day 2 itself, patient start having pneumonia or urinary tract infection, and we mostly attribute earlier it to because of some nosocomial infection, something because we have put some catheter or a tube or IV line. So probably, but this DNA itself is like working like a pathogen. It's producing massive inflammation in your body. And that is why big amount of DNA in your body can actually predict complications like pneumonia or UTI. So what do you do then? What do you do then? You give antibiotics, antivirals for pathogens. So what do you do? Body already has DNAs in our system, in our blood. So DNAs will degrade DNAs 1 and 2, so that will degrade. But when there is a massive release, body cannot handle that. So you have in pharmacology something called DNAs. This is a commercially available drug. So this could be a target to treatment, which so far, it's not been thought like this. So this could be a target to treatment also. So this is the beauty of having this biomarker. So there is a cytokine storm. Another interview, because I will be sharing you certain things which I found very interesting, and what is missing in our present stroke treatment, anywhere in the world. See, stroke, heart attack, you all know it is dealt mostly with Obviously, drugs for that would be some blood thinner or some cholesterol lowering agents, antihypertensives, sugar medication and like that. Okay, you don't have any kind of insult to your brain or to your heart would have a lot of inflammation. We don't have any good anti-inflammatory medication in our armamentarium to treat stroke or heart attack as of now. Statin, which is cholesterol lowering drug, has some anti-inflammatory property, but it's not a very robust anti-inflammatory. In a massive heart attack or stroke, you don't have any medicine. So there's a big missing link in treatment of these conditions. So with this cell-free DNA, I realized over a period of time when I started, from last 10 years I'm working on this. So when we published first time in 2020. So what is so in India? So okay, we don't have any anti-inflammatory. What do? Very difficult to take permission for a drug trial from DGCI outside any institute. Okay, so we have, like I was talking to some of the pharmacology books you are taught. This is something we have in our household, in our kitchens. We all have this. Okay, so turmeric. Turmeric has curcumin. Curcumin is a very potent anti-inflammatory drug. In standard pharmacology, medical pharmacology books, this is not considered a drug. You have read about turmeric, curcumin, because you are not governed by NMC. NMC guided books doesn't have curcumin. So the problem for me, if I cannot conduct a trial, turmeric milk is given to all of us in our childhood. Okay, what I did 500 patients. I started randomizing people whom I gave turmeric milk with 1 teaspoonful of turmeric along with a dash of black pepper, because turmeric for our stroke patients. And interestingly, when we were randomizing, the patient who was in neighborhood of that patient who was receiving turmeric milk, the other person was also, because we have a faith also in turmeric that it does very well to our body. So this is one just small thing I wanted to show you, because we have to think beyond established things. When we started doing mechanical, from back to me, I was take 24 hours. If you have a stroke patient, okay, the artery to the brain is blocked. What you do? You take the patient into a cath lab, do a brain angiogram, see the blockage there. With your retrieval devices, you take the block out. It takes 10 minutes. Just 10 minutes procedure. So when we started retrieving, so from last 10 years, all over the world, now this modality is available in all major institutes. Okay. So we started subjecting these thrombus samples to new generation sequencing, because brain is a sterile compartment. You will not have any culture positive thing there. So in initial few patients only with new generation sequencing, we could identify almost 27 bacteria. Now how the bacteria is there in your sterile brain? Is it contaminant? So what I am trying to share with you, certain innovative things which probably would be a future game changer thing in times to come. These bacteria were commensals, low grade virulents or non-pathogenic, sitting in and around our body, in your gut, in your skin. Okay, so somehow they transgress your blood stream. And how do they produce stroke and heart attack? Because that's a different topic, I will not go in details of that, but they produce stroke. So apart from standard risk factor mentioned in medical literature like hypertension, diabetes, sedentary lifestyle, smoking, obesity, is a standard risk factor for any heart attack and stroke, we all of us know. So we propose this risk factor which we call Vidra. Vidra in Sanskrit means lack of hygiene. So any kind of hygiene related factor could be additional risk factor for having a stroke or heart attack. So these are already various biomarkers described in literature done, that probably higher cell-free DNA leads to mortality. Higher cell-free, which is common sense. Okay, the first trial, this is mortality. Some trials have that they have a poorer outcome. If you have higher cell-free DNA level, they have poorer outcome. So we were actually, our idea was for therapeutic optimization, not for knowing, mortality would be more if your half of the brain is gone. So we did this was our first study that was published in 2018. So these were 26 patients, initial patients with proximal middle cerebral artery occlusion, that's the main brain artery, which was occluded. We took 5 ml of venous sample for this cell-free DNA within 6 hours of stroke onset. And they underwent standard imaging and workup and treatment. So I'll just in brief, I'll show you. So here we were doing DNA extraction in these patients, and by RT-PCR we were quantifying cell-free DNA. Okay, so this were the demographic data of the patients. So this was our cell-free DNA in an NIH, that's stroke severity scale. So NIH stroke severity, so higher the cell-free DNA, higher is the stroke severity on admission, and MRS is the outcome assessment scale. Higher the cell-free DNA level, poorer the outcome at 3 months. Usually stroke trials, we take 3 months as an endpoint, and you continue it further. Okay, so this was again one thing, we came to somehow this level of 10,000, that less than 10,000 had good outcome, more than 10,000 had bad outcome. And this was why this was important. It is not only for this outcome thing. When we were treating these patients by thrombectomy, the patient who underwent, because thrombectomy, these are all blind procedures. You have a stroke, patient landing in ER, you do a CT scan, CT based protocol, you find the occlusion on CT scan, take the patient in the lab, open up the vessel. So that's standard protocol. A bedside something which tells you would be much more, easier to access even in the remotest of area where MRI and CT suits are not there. Okay. Then secondly, this is very inexpensive and you can do it repetitively. You can do it again and again. You cannot send a patient from morning and evening to an MRI suite. Okay. So those patients who had lesser level had better outcome with your thrombectomy also. So in a resource poor area like ours, if somebody has to, pay 3 to 4 lakh rupees for a thrombectomy, if I know the patient is not going to do better with this kind of treatment, I better withdraw that. Okay. So basically, this is, those who work in, this is a very common thing you see in molecular biology lab, nanodrop. You do DNA purification and then RT-PCR you do. So these were the initial few papers we published, clinical usefulness of cell-free DNA as prognostic marker in acute ischemic stroke. So these were mainly ischemic stroke. Now we knew we have something very good in our hand. But the problem here was, with nanodrop only, you have some impurity many times and your results may not be very correct. So you have to, do RT-PCR after extraction. So the whole thing was taking 5 to 6 hours. So because initially these were research setting, okay, these were not the patients, we took sample, refrigerated at -80, and then we analyzed everything at one go. Okay, so that was not in real life. So but the problem here is it takes 5 to 6 hours. 5 to 6 hours makes no sense in clinical practice. 6 hours your brain is gone. So you have to have something which is, quickly available to you. So we needed some kind of POCT testing, point of care testing type of system. So this was nanodrop, but because this is evolution of, this work. Nanodrop, we published this data based on, what are the mild, moderate, severe stroke. But nanodrop, nowadays, in most of our ICUs, we have patients with brain infection, meningoencephalitis. You test for 52 bacteria and viruses which affect brain in one go in 20 minutes to get the report. So we have this cartridge-based system. In India also, one of the company in Bangalore, Neodix, they make this system. This very cheap system also, they make it. So it is extraction, RT-PCR, everything is in cartridge. Okay. So it is one-time procedure. So we talk to these guys. If you can detect 50 bacteria and viral DNA in 20 minutes, why can't you give cell-free DNA? So we work with them, and probably, this is still since this is ongoing. This thing is, and even in future, because in molecular biology, this DNA nowadays you have DNA chips. So this could be a point of care testing. So what do? You have a platform, you put DNA probes and you detect by various things. By maybe with your smartphone, if you have some, you colorimetry, how much colorful the image comes, you can actually measure with your smartphone that this is going to be value once you study. We don't have as of now. This is lateral flow assay. You must have seen pregnancy kits, pregnancy strip. You test positive pregnancy, negative pregnancy. Okay. So maybe in times to come, lateral flow assay. So you load the sample here, your blood sample here through this nitrocellulose membrane. You have test line, control line. If both are positive, probably this is going to be for cell-free DNA also. So this is again my own speculation. this is not there anywhere in the world as of now. Then coming even next, paper-based analytic devices. Because when I think of India, I think of 146 CR population. Any kind of CT, MRI in our country is going to be, less in quantity. Wherever so many All India institutes have opened up in this state only. But our population is such big, we have to, and stroke is a major cause. So you have to have something which can be available, right in small towns and villages and these areas, in peripheral, what we call PHCs, primary healthcare center, when there is a one doctor, one nursing staff. Okay, so you have to have something which is affordable, sensitive, specific, user-friendly, rapid and robust, equipment-free, deliverable to end user. So this is what WHO says. The biomarker should be all about assured criteria of a biomarker. So we need to have something of this kind. So for this you can have this. Again, this is also we are in talk with a Chinese company for this, because they probably do it. They make this origami paper where they do wax printing and wax dipping, and they make channels. You put the blood there, and if you have you put this DNA, it seeps through capillary action, microfluidic action, and you have that primer of DNA there. So this is, as of now, we could say it is present or absent. We are not able to quantify with this thing. Already preliminary studies have shown presence or absence, but so far we have not been. But in times to come, probably this should be possible. So this paper-based analytic devices is again very important thing to watch for. And obviously in future, you combine DNA with proteins, RNAs, metabolites, and make it a AI-based comprehensive panel that could again predict it much better. So I think I would finish here because my talk is slightly not usual one. I mean, not pure. I'm not a pure researcher also, but this is something which is very important, cell-free DNA. So here I found it very useful, so I thought I'll share with you. If you have any questions or comments or queries on this, you're most welcome. Thank you very much.